moderating this session. I'll be moderating this session. I'd like to just introduce the speakers for today. We will have two main speakers. Our topic today is primary immunodeficiency disorders, and we shall have both the scientific approach and then we'll have a patient perspective. So Dr. Anne Baraza will be taking us through the scientific presentation. And Anne Baraza, as you can see on the screen, is a clinical pathologist. She has a keen interest in immunopathology and clinical diagnostic immunology. She heads the thematic unit of immunology in the Department of Human Pathology at the University of Nairobi, Faculty of Health Sciences. She's committed to enhancing the diagnosis and treatment of immune-related disorders, and she currently serves as the president of the African Society for Immunodeficiencies. Before I welcome Anne to speak, I would just like to mention that this week is World Primary Immunodeficiency Week, and that is why we are having this webinar this week. And during the World Primary Immunodeficiency Week, the goal is to create awareness, promote education and research on primary immunodeficiencies with the aim of improving health outcomes. Now, once Anne is done with her presentation, we will have another speaker called Helen Ayaga, who is, she's a lawyer by training. She has worked in the NGO world since 2002. And she has a passion for social justice. Now, today she will be here to talk to us about living with a primary immunodeficiency. So she will bring the patient perspective. She has a daughter who is living with a primary immunodeficiency, and this is combined B and T cell immunodeficiency. So I will hand over to you, Anne, to take us off.
Okay, thank you, Cynthia. Nelson, I think I will stop your screen sharing and upload mine.
Go ahead.
Okay, so I will start right away. Thank you for the introduction. So primary immunodeficiencies are inherited disorders which are caused by defects either in the development of the components of the immune system or in their function, or both. Globally, it's estimated that 1 in every 10,000 people has a primary immunodeficiency. So it's actually thought that there are more than 6 million people worldwide who are living with a primary immunodeficiency. The problem is that 70 to 80% of these people remain undiagnosed. Now, depending on the type of defect, generally what component of the immune system is affected, and on the severity, the manifestations of these disorders can either begin as early as in the newborn period or as late adulthood. So there's a varying spectrum in terms of the age at which patients will manifest. But most commonly, they present in infancy and early childhood, and these tend to be the more severe defects. The major presentation will be with infections, but we also see some non-infectious complications. So what causes primary immunodeficiency disorders? I mentioned that they're inherited, so they're genetic disorders, and specifically they're monogenic disorders, meaning there's a single gene defect. As of 2022, through the International Union of Immunological Societies, who basically does the classification of these disorders every 2 years, so as of 2022, there are 485 distinct primary immunodeficiency diseases, okay? And what you said is that there's an abnormality with a gene that is responsible for example, production of a particular immune cell component or regulation of a particular immune process and so forth. So when there's a change in that gene, there's a mutation, you get a variant that will change the product If it's a cell, it changes the cell that was going to be produced. If it's a cell marker, it changes that cell marker, and so forth. So you either get increased expression of whatever protein was supposed to be there, or more cells than would be needed, or you get decreased expression. Okay. So primary immunodeficiencies may sound like they are new disorders, but they are not. They've been there with us for many years, and they were actually discovered before the advent of HIV/AIDS in the early 80s. So in 1950, there's this guy called Glanzman with his colleague Grinica, who described an infant with severe lymphopenia, so very, very few lymphocytes, which are some of the immune cells, and hardly any lymphoid tissue. That's the atrophic lymphoid tissue. And this infant succumbed to infection early in life. And in the same year, there's another scientist, doctor called Kosman, who described the first patient with a severe congenital neutropenia. So patient born without the other white blood cells, the neutrophils, okay, which was at that time named, the disease was named after him. Then in 1952, Bruton, yet another physician, described an 8-year-old boy who presented with recurrent pneumococcal sepsis. And, on further evaluating him, he was discovered not to have any antibodies, the gamma globulins. And when he treated this patient with intramuscular injections of the antibodies, the gamma globulins, he was actually able to recover. So that is when Bruton's disease, or X-linked gamma globulinemia, was discovered. In 1954, Janeway, if you've been a student of immunology, the book written by Janeway, described a patient with recurrent infections, but paradoxically had very high levels of antibodies. And 3 years later, it was found that this boy actually suffered from a phagocyte defect. And what he was found to have was chronic granulomatous disease. So his antibodies were working fine. He was producing a lot of antibodies, but he was still getting infections. And it's because his phagocytes were not functioning well. In 1958, Hitzig and other colleagues described more patients, infants, with early onset life-threatening infections, and on characterizing these patients, they were found to have very low or absent antibodies and lymphocytes. So this is when they described what they called at that time the Swiss type gamma globulinemia, to differentiate it from what was described by Bruton's. And later, this is what we now know as SCID. The terminology was changed to severe combined immunodeficiency, because there are no antibodies, there are no lymphocytes. In the 1960s, other people now discovered that you can have primary immunodeficiencies that affect the complement system. So currently, as I mentioned, the IUIS classifies these defects into 10 groups. The first and second actually, constitute what we call the combined immunodeficiencies, which means they affect both the lymphocytes, which provide our cell-mediated immunity, as well as the production of antibodies that come from the B lymphocytes, which provides our humoral immunity. In the first group, they have what we call the severe combined immunodeficiency, which you'll later hear me calling SCID. And in the second group, these are combined immunodeficiencies that are less severe than SCID, but are associated with syndrome. So there are other abnormalities in other organ systems aside from the immune system. Then the third group would be the predominantly antibody deficiencies. And then we have diseases of immune dysregulation. We know very well that for every process in our immune system, there's a level of control. There are always checks and balances. So all our immune processes are tightly controlled. So you may have, normal immune cells, but they're not functioning well. That's what we're calling dysfunction or dysregulation. So you get uncontrollable responses. That still presents with pathology. And then we have the defects of the phagocytes, which should either be they're too few, or they're there, but they don't function well. And then defects in intrinsic and innate immunity, our autoinflammatory disorders, complement deficiencies, And the newest additions from maybe 5, 6 years ago are the bone marrow failure syndromes. We see this in hematology, but there are also immune defects because all our immune cells come from the bone marrow. So if the bone marrow is not working, we do not have our immune cells. And finally, the phenocopies of the primary immunodeficiencies. What I haven't mentioned is that because there are some phenotypes of PIDs, which will present more with dysregulated immunity than infections. The terminology later changed to inborn errors of immunity, but people still are calling PIDs the ones that manifest majorly with recurrent infections. So phenocopies of inborn errors of immunity are caused by somatic mutations that, for example, would cause production of maybe autoantibodies that will interfere with some of the immune components, okay? So someone is born with a normal immune system, something happens down the line, they get these abnormal autoantibodies which affect the functioning of the immune system. A good example of this would be in a category of patients who developed severe COVID-19, they were found to have autoantibodies to type 1 interferons, which are cytokines that are very important for our early immune responses to viral infection. So because they were not able to control the viral infection very early, then it was able to propagate and spread. Now, a broad and simple classification would be to just categorize our immune defect according to the component of the immune system affected. So broadly, we have the innate immune system, the one we are born with. It's the same, a germline. The response is always the same. And it includes our phagocytes, which are our white blood cells, our non-lymphoid white blood cells, and our complement system. And then the other category would be our adaptive immune response. This is our very sophisticated, highly efficient, highly effective immune system that consists of our B lymphocytes and our T lymphocytes. And our B lymphocytes usually interact with the T lymphocytes. The T lymphocytes give them some direction so that they're able to produce good antibody. So this pie chart is just showing us the distribution of our primary immunodeficiencies by type. We've said all components of the immune system can be affected, but generally the antibody deficiencies are the most predominant. They account for about 55%, so slightly over half of our patients with primary immunodeficiencies. And then we have our combined T and B cell immunodeficiencies, and then our phagocyte defects. And then you can see the other categories actually don't contribute much. Our immune dysregulation, autoinflammatory, and complement. So how do these disorders manifest? The hallmark, or what would make us think a patient has an immunodeficiency, whether it's primary or secondary, is that the immune system is not working. So it's not protecting them from infection, so they present with infections. Now, in patients with primary immunodeficiencies, these infections tend to be frequent. They're very recurrent. They tend to be severe. They tend to be atypical. For example, they're caused by pathogens which don't cause infections in people with an immunocompetent immune system, or they involve very unusual sites, okay? Now, the infectious predisposition, if you compare patients globally, may also differ depending on where the patient is. So geographical regions, there are some infections that are endemic in some areas and not in others. Social determinants, the living environment, sanitation, things like that. And of course, on the component of the immune system that is affected, okay? Aside from infections, because of the aspect of immune dysregulation, these patients can also manifest with severe allergies, autoimmune manifestations, autoinflammation, as well as lymphoproliferative disease and malignancies. Now, there's a society or foundation called the Jeffrey Model Foundation that does a lot of advocacy work and awareness creation for primary immunodeficiencies. It was formed by the parents to a boy called Jeffrey Model, who had a primary immunodeficiency, okay? And they've been able to put together what they call the warning signs of course, working with physicians and immunologists. So warning signs of primary immunodeficiencies. The purpose of this was, to be able to create awareness, especially amongst, primary care health personnel who would be the first contact with patients, to make them aware and, be able to determine when they think a patient has a primary immunodeficiency and when they should send them for further evaluation. So there are 10 warning signs for children. Initially, this began with children, basically alluding to types of infection, numbers of infection within a year, the sites of the infection, is that infant gaining weight and stature properly? And, when they have infections, are they getting better if they receive oral antibiotics, or do they now have to get admitted and receive long courses of intravenous antibiotics and so forth? But one of the key features that would actually point towards a primary immunodeficiency would be a family history. Someone else in the family having either the recurrent infections or having been diagnosed as having a primary immunodeficiency. Now, we said that these PIDs can affect adults as well, not just children. So they've also been able to put out warning signs for primary immunodeficiencies in adults that are slightly different from what we have in children. As I said, the purpose of this is just to know when should you suspect and send this patient for evaluation. And for both of these categories, the presence of at least 2 of the signs should create a high index of suspicion. So how do we go about diagnosing primary immunodeficiencies? Of course, it starts with the medical history. We've said these patients present with recurrent infection. So that's part of the medical history. And then, we'll move forward to a physical examination and then start our lab evaluation to actually test the function or the components of the immune system being present. So I'll just mention a few clues that would guide you, things you need to tease out from the medical history. As I said, family history is very important. So in the family history, you want to establish whether there's history of consanguinity. We say these are genetic disorders. So many of them are caused by or are transmitted by, or inherited in an autosomal recessive fashion. And we know that if you carry one autosomal recessive gene, you're a carrier. The normal gene will still, the non-mutated gene will still function normally. But if within a consanguineous family, you may have 2 people coming together to have children who are both carrying a mutated gene, which they inherited in an autosomal recessive fashion. So in such a situation, then the progeny would now inherit 2 defective genes. So then they will now manifest with the actual disorder. So history of consanguinity, this has been noted to be very significant, especially in the Middle East and North African regions where there's a lot of consanguinity, and they actually have a much higher prevalence of primary immunodeficiencies than in other parts of the world. The other important history in the family would be, trying to elucidate whether other members of the family have been having recurrent infections or have a history of recurrent or unusual infection. If we're thinking about disorders that are inherited in an X-linked fashion, you'd be asking about males, okay? And not just, siblings, but also asking from the maternal side of the family, the maternal uncles and so forth. The other significant thing would be early childhood mortality, so early infant deaths within a family, either from infections or unexplained causes. Okay, then we have the vaccination history. We know the pediatricians are very good at looking at our vaccination schedules. Of course, if there have been some missed vaccinations or immunizations, that can explain, susceptibilities to certain infectious diseases that have vaccines. But we also need to ask about history of adverse effects to live viral vaccines, okay? Usually the live viral vaccines, the live vaccines, but the pathogen has been weakened. So someone who has a competent immune system should actually not get an infection from that vaccine. But if someone is immunocompromised and you administer live viral vaccine, they can actually manifest with the infectious disease. The other things to tease out from the history are the aggravating factors. So ask about, sanitation, history of allergies, find out whether this child only started manifesting when they started, going to daycare, or they're living or being put in an environment where there's overcrowding, if there's passive smoking in the house, that can predispose to respiratory infections. Nutrition is important. We know that malnutrition is the commonest cause of a secondary immunodeficiency globally. Of course, in the context of primary immunodeficiencies, if you're having a child who's always sick, they may also not be feeding well. So the two things may compound each other. Also ask about medication history. There's some medications that can interfere with immune function. Then as we're trying to determine, what infections this child is having, if you're told there's a history of recurrent infections, you need to determine the pattern of infections. Is it always the same site? What sites are getting infected? Are there microbiological results? It's important that we send our biological specimens for culture so that we can actually know what pathogens are causing infections in this patient. So in the context where you're only having infections in one site, think outside the box. Think that, it could be an anatomic problem or an intrinsic problem. For example, maybe like an inhaled seed, and this child is always having respiratory tract infections. Okay. In the physical exam, there may be some clues. In children with milder defects, you may not find, aside from the signs of infection, you may not find much. But in those with severe defects, especially in children, they're not going to gain weight normally, so there'll be failure to thrive. They'll be quite underweight. You may have some hair changes. There's some PIDs that are associated with partial albinism, for example. You might have some end organ, damage or manifestations. For example, a child with recurrent otitis media would have, scarred tympanic membranes. People, children and adults who've had recurrent lower respiratory tract infections would have lung damage with bronchiectasis, which is end organ damage. Look for the presence of an enlarged spleen or liver or lymph nodes. And in that case, you'd be thinking either in our setting of HIV or immune dysregulation. Look at the skin. The skin would tell you whether there've been recurrent skin infections or abscesses. If there's scars present, look for the presence of rashes, warts, and so forth. And importantly, which we never think about, especially in children, when we examine the throat for hyperemia, absent tonsils. If the tonsillar pillars are not prominent, that could be a sign of an antibody deficiency because they don't have the B lymphocytes, which occupy the germinal centers of these lymphoid organs. So we basically try and put together the clinical phenotype from the history and physical examination with the lab phenotype, in this case being the pattern of infections and the type of pathogens involved. So this is just a small example that can give guidance for children, very young infants, so less than 6 months of age, who start presenting with infections early on, and they tend to be opportunistic, or even the whole spectrum of pathogens. They have viral infections, bacterial infections, mycobacterial, and even vaccine-induced infections. Then you start thinking of severe defects such as a combined T and B cell immunodeficiency. If in the clinical manifestations you're seeing other organ systems being involved, for example, some dysmorphism, maybe cardiac defects, and so forth, think about those that are associated with syndromes. For children or adults who majorly have antibody defects, but their T lymphocytes are fine, usually they'll be predisposed to sinopulmonary infections, majorly caused by encapsulated bacteria, so our H. influenza, strep pneumo, because they don't have the antibody that would serve as an opsonin that would assist with the phagocytosis. So recurrent respiratory tract infections, but they also tend to have chronic enteroviral infections that present with chronic diarrhea. The difference between the predominantly antibody defects and the combined defects is that the predominantly antibody one, if they manifest in younger children, in infants, usually it will be after 6 months of age, once the maternal antibody starts to wane. For adults, autoimmune cytopenias can be a sign. If they're having autoimmune cytopenias, with or without infections, there's actually a possibility of an antibody defect, for example, the common variable immunodeficiency. For the phagocyte defects, generally these patients would have recurrent skin infections and abscesses, infections around the mouth and the jaws, the gums, as well as deep-seated abscesses, okay? And in terms of the pathogens, majorly bacteria, especially the catalase-positive bacteria like Staph aureus and Pseudomonas, but they can also get infections, especially in endemic regions like ours. They can get recurrent mycobacterial infections. For complement defects, it depends on what components are missing. If it's the early components of the classical pathway, they present with an autoimmune-like disease, basically a lupus-like disease, and could even have kidney pathology because of that. If it's the C3, which is where all our complement pathways meet, they would actually present with recurrent bacterial infections. But if a child has such a complement defect, like missing C3, but they have normal antibody, by the time they're about maybe 3-4 years of age, then these recurrent infections because of the missing C3 will not be a major manifestation because they have the antibody. For the late components, they'll actually present with recurrent invasive meningococcal disease. So once we put this together, this is supposed to guide, information is supposed to guide how we go about evaluating these patients in the lab, okay? So it's recommended that we start with an initial immune screen, which the results of which are going to give us information as to the likely component of the immune system that is affected, and then that is the one we can interrogate further, okay? In our setting, any patient with recurrent infection, the first thing we want to do is rule out HIV, okay? Okay, so I just basically divided this into the 4 components, the major components of our immune system that could be affected. I'm trying to move this, it's not going. So basically our lymphocytes, antibodies, complement, and phagocytes, and just trying to show, you know, the stepwise approach to testing, okay? I think I've already given you clues from the clinical history and physical exam that would make you think, oh, this could be an antibody defect, or oh, this could be a combined defect. So for the combined defect, the major defect, even if we do have the antibody, because there'll be no B cells, so no antibody, but the major defect is because our T cells are not working, okay? So routinely available test is our hemogram, our full blood count, okay? Where we'll be able to look at our lymphocyte counts. Our predominant subset of lymphocytes circulating peripherally in blood is a T lymphocyte. So a child, an infant, a child less than 6 years of age, with a persistent lymphopenia of less than 2 million lymphocytes per liter of blood is having a severe combined immunodeficiency until proven otherwise. So if you have, you know, this sort of lymphopenia, together with that clinical history I've mentioned, this is a child you want to evaluate further and immediately, because KID is a medical emergency. So the next thing to do here would be to now determine, out of these lymphocytes, how many are T cells, how many are B cells, how many are natural killer cells. Okay, so that's the lymphocyte subset enumeration, not readily available in major settings. Actually, currently in the country, the only clinical diagnostic lab doing this is at Aga Khan. So for other patients, if we don't take that, we'll outsource elsewhere. And it's also not very cheap, but, you know, gives a lot of useful information. This can actually be done in all the centers that were performing CD4 monitoring for HIV, if the reagents are available. Now, if the T lymphocytes are less than 300 cells per microliter of blood, that's a SCID, okay? The other test that could be done, so in such a case, I would directly just send that child for gene sequencing, because KID is not one disease. Here, the development of our T cells and B cells is affected. There are many things in the pathway that can interfere with the development of these cells, okay? So I would directly send that patient for a genetic diagnosis. But in other centers, you can actually do, if it's not very clear, you know, borderline numbers of our T and B cells, you can actually look at the function of these cells. These are in vitro assays, stimulation assays, just to see how these lymphocytes are responding either to antigens or to mitogens, things that would cause them to proliferate, okay? The other assay would be looking at thymic output, just trying to determine how many T lymphocytes have developed. Because remember, our T lymphocytes are the ones that mature in the thymus. So there's this assay called the T receptor excision circles. It's a PCR assay just to determine, how many lymphocytes, T lymphocytes have matured from the thymus. And actually in countries that do newborn screening for SCID, because I mentioned it's a medical emergency, this is a test they do. So all babies when they're born have this assay done. Those with a low TREC count now undergo further evaluation. Now they'll do the TB&Ks. For the antibodies, guided by the clinical history, we immediately just want to determine what are the serum immunoglobulin levels. So we can assay the total IgG, IgM, IgA, okay? IgD not expressed as much, so we don't assay for that. IgE, I would say I would assay for it if in the clinical phenotype of the patient, I'm also seeing allergic manifestations, okay? Because the problem here would be very, very elevated levels of IgE, okay? So this test is also it's not readily available in public facilities in Kenya. A quick clue or guide can be your calculated globulin. When you do your liver function test with the total protein and albumin, the globulins would be the total protein minus the albumin. It's not been validated here, but has been elsewhere. Probably it's something we can do locally, but a calculated globulin of less than 18 correlates very well with a hypo or with low antibody levels. Then for further evaluation, this would be to look at vaccine antibody responses, just challenging these patients with protein and polysaccharide vaccines to see the response, which would tell us, give us information about our T-dependent and T-independent immune responses, because sometimes it could just be a specific antibody deficiency. Maybe you're not responding well to protein antigens, but you're responding to polysaccharide antigens. B cells can also be enumerated. So, depending on the context of the patient presentation, this can be done as part of the TB&K enumeration or in isolation. And I'll skip the anti-cytokine antibodies. And generally, the confirmatory test would be the gene sequencing. Okay, for the phagocytes, our phagocytes circulate in blood. The major subset would be the neutrophils. So a full blood count will give us information as to the numbers, okay? In our severe congenital neutropenias, they are very, very low, okay? So neutropenia would be easily picked up. Now, neutropenias are not uncommon in children, especially when they have viral infections, okay? So to document a neutropenia of concern, you would have to do serial counts probably every 2 weeks, okay? And in a severe congenital neutropenia, either they would always be low or you'd have a cyclical pattern, just depending on, what the genetic defect is, where, every 2 weeks or so there's a dip and then they come back to normal and then dip again. So that's the importance of doing the serial count. In leukocyte adhesion defects, here our neutrophils are not able to participate in the inflammatory process where they, roll onto the blood vessels, adhere, and then they're able to extravasate to go into the tissues where the infection is. So this is a patient who's producing neutrophils as normal, but they can't go where they're needed. So there'll be high neutrophil counts. In terms of functional assays, so a patient may have neutrophils, they're just not functioning. So remember the function is to phagocytose. They come to where the bugs are, they phagocytose them and then destroy them, either using enzymes or oxidative mechanism. So there's a way to test the oxidative mechanism called the respiratory burst. It's defective in chronic granulomatous disease. So there are 2 assays available for this, not available locally, but they are there. One is flow-based, it's called the dihydrorhodamine assay, and then there's the nitroblue tetrazolium test. Other functional assays are also available. So for example, for the leukocyte adhesion defect, we can actually, what is missing is the adhesion molecules, like the integrins on the surface of the neutrophil. So it cannot attach onto the endothelial cell. So we can actually evaluate for them using flow cytometry. Confirmatory testing would be genetic. For complement defects, generally to screen whether the complement system is working, we start with the hemolytic complement activity, where you can actually assay the classical pathway, the alternative pathway, as well as there's an assay for the lectin pathway. Then the one that has low activity is the one you'll evaluate further, okay? If all of them have low activity, then generally you'd think the problem is at the terminal level, okay? Confirmatory testing would either be functional assays or genetic testing. Genetic testing is important because that is what tells you definitively what the disease is. It helps us understand the pathophysiology of that disease. It gives an avenue for targeted therapy. So for example, for gene therapy, unless you know the defect, you cannot provide gene therapy. Provides an avenue for genetic counseling, helps you prognosticate, and it's only through gene sequencing that we've been able to know that there are currently 485 PIDs. But what I just want to highlight is that, genetic testing does not replace the functional immune evaluation, okay? So it's as much as it's going to give a definitive diagnosis, you don't jump from seeing a patient and saying, oh, they may have a PID, and directly bring the genetic testing. So principles of management, in these patients, you want to treat any infections, prevent other infections. So antimicrobial treatment and chemoprophylaxis, guided by the defect and what pathogens cause infections in these patients. Of course, the caregivers and the patients, if they're older, should be encouraged to have good hygiene practices. For severe defects, the combined ones where you cannot administer live attenuated vaccines because it'll cause an infection, then you want to vaccinate the household contacts and family members. For those who are admitted, you probably want to isolate them, not put them, together with other patients with infectious disease. In the case of transfusions, then for the severe combined immunodeficiencies, the products need to be irradiated and CMV negative. You don't want to transmit CMV. Our seroprevalence, I think, is in the 80% and above. And you also don't want to predispose them to graft versus host disease. The other principle of management is to replace what is missing. Antibodies are missing, like in a predominantly antibody deficiency or in a SCID, then we can replace the immunoglobulins that's available. For other conditions, there are targeted biological therapies. For example, if in a Mendelian susceptibility to microbacterial disease, interferon gamma is missing, there's actually available interferon gamma. Definitive treatment is basically hematopoietic stem cell therapy or gene therapy. Okay, now I'll just quickly, as I wind down, just talk about PIDs in Kenya. Do PIDs exist in Kenya? Yes, they do. The first documented, I'll say documented because maybe there were others that were just not picked up before this. So the first documented case was in 2014. This was published by Dr. Walong from a clinical autopsy. And this is a patient we think had DiGeorge syndrome where the thymus did not develop. So gave a SCID-like immunodeficiency. There was family history of, I think, 2 or 3 other babies dying early. And then there was a lull. And in 2021, okay, so around 2018, we started advocacy and awareness on PIDs in Kenya, and we were able to pick up other patients. So other documented cases in 2021, 3 cases from one hospital and 1 from another. All 4 were SCIDs, although we didn't have genetic diagnosis. I'll talk about this other case later, but I just wanted to highlight that, yes, we have these cases. So with the advocacy and awareness education that we've been doing, we currently have, there could be slightly more. These are the ones I know of now, 13 children diagnosed between 2018 and 2023, many evaluated, okay? Of course, we evaluate, we don't want all of them to have PIDs. We just want to rule it out. 8 males and 5 females. The age of diagnosis is variable, all the way from birth to 17 years. We are really missing many of the adults. All of these patients presented with a history of recurrent infections, except for one who was a newborn but had a sibling who had died 3 years earlier, so was screened at birth, okay? 8 you can see the positive family history, very strong sign. 8 had a positive family history of early sibling death. There was no history of consanguinity. In terms of the categories, many of them are combined immunodeficiencies. And if you remember the pie chart I showed you, our commonest, or rather from the rest of the world, the commonest PIDs are the antibody defects. So we wonder, where are our antibody deficiencies? Maybe we're just not picking them up because we're not thinking about them. So out of those, there are 3 severe combined immunodeficiencies, 1 late onset severe combined immunodeficiency. This was a 17-year-old girl with a very, very low CD4 count, HIV negative. This immunodeficiency is also one of the newer categories of the combined immunodeficiencies. The hyper IgE is also a combined immunodeficiency. Okay, so we're picking the rarer forms. The antibody deficiencies, maybe only 3 patients. We have 4 patients with phagocyte defects. So currently, out of these 12 are alive, 10 on follow-up. 2 have had definitive treatment. So the kid that was picked up at birth and a patient with chronic granulomatous disease, also picked up in early infancy, have actually had definitive treatment. They were sent out for hematopoietic stem cell transplant. So better scenario than before when we were picking up these cases from autopsy. So what challenges have we faced? One is inequitable access to diagnosis, especially in the public facilities, the cost of the test. Even in the private facilities, many of the tests are outsourced and they're expensive, okay? For the genetic testing, sometimes the results that come back tell us, there's an abnormal variant, but we don't know if it's pathogenic. So trying to, even though we have genetic counselors locally, because we don't have access to many functional immune assays, it's very difficult to curate these variants to determine whether they're pathogenic or benign. So what this leads to, especially the inequity in access to diagnosis, it leads to delayed diagnosis, which correlates with poor outcomes. And even if we finally diagnose, access to treatment is also an inhibiting factor. So all this impacts on the quality of life of these patients. And one major concern, as I mentioned, for example, the antibody defects, it's likely that we're not picking up many cases, and most likely this is because of low awareness, and especially because we actually don't have a national registry. And, maybe, yes, we live in the tropics, we have endemic infectious disease, and probably this could be masking, like we treat the infectious disease, but we're not thinking beyond that. So they could be masking some of our PIDs. So what we need to do to try and counter this is just to continue creating awareness, continue educating people, and probably looking for more collaborations, working. Like I mentioned, it's only unfortunate that now we're not doing CD4 monitoring in HIV, but if just that program was still going on, we could leverage on that to enable TBNK evaluation if indicated, okay? We need to continue lobbying through patient groups. We do have a patient group in Kenya, the PIDs Kenya, that's founded by Cynthia. We need to implement the WHO Essential Diagnostic List. So because of advocacy from global PID regional societies, WHO actually included the basic immune screen as an essential test. For us as a country, we haven't included this in our national essential diagnostics list. We probably need to embrace that. And of course, at the end of the day, we can only learn much more about our setting if we establish a national registry and centers of excellence. So I'll conclude by saying that PIDs exist. We just need to make more effort towards diagnosing them. In the setting that you have a patient with you suspect has a primary immunodeficiency, exclude secondary causes first, because those are more common. When it comes to evaluation, it should be systematic and stepwise so that, every test you're doing is giving you information, okay? We're not just testing people for the sake of testing them. And when it comes to interpretation of results, this should be done within the context of the individual patient and the current clinical scenario. And this is where I'd really advise that we talk to your clinical pathologists, okay? We need a collaborative approach for, aside from the infectious manifestations, many of the other manifestations cross-cut other medical disciplines. It's not just infectious disease. It could be pulmonology, rheumatology, neurology, and so forth. So we all need to be talking, hematologists and so forth. And once we pick up these patients, we need to address their psychosocial issues. We need to educate them. And, we need to provide a form of support. And that's the purpose of the patient group. These are the colleagues I've been working with in this field in Kenya, and I just acknowledge them. Thank you.
Thank you very much, Dr. Baraza. That was quite an insightful presentation. I particularly liked the statistics you provided on PIDs in Kenya, that yes, they are rare, but they definitely do exist. I'd just like to also acknowledge Dr. Diana Marangu and Dr. Edwin Walong, who are also on this call, and I think you mentioned them on your last slide as doctors involved in PIDs in Kenya. Now, the next part of this webinar, I'd like to just ask Helen. I think Anne mentioned that it's important to have a collaborative approach in the management of PIDs. And I guess collaboration is not just with medical experts, but also with the patients. So I would just like to have a discussion with Helen. I mentioned Helen has a daughter who is living with a primary immunodeficiency. And Helen, are you there?
Yes, I'm here.
Great. Maybe just to kick us off, Anne mentioned some challenges that patients with primary immunodeficiencies face. And maybe I'd just like to ask you, what challenges did you face when you're seeking diagnosis for your daughter? So what were some of the obstacles and challenges basically in diagnosis and also accessing treatment and medical care?
Thank you, Cynthia. And yes, Dr. Dan, I have to give you a shout out because you've been in this journey with me from the beginning till now. So my lovely daughter, Yara, who's the reason why I'm here, is going to be turning 4 in the next 2 months. So that means there's something we are doing right. So challenges, Dr. Baraza has mentioned some. She's mentioned some challenges, but maybe just to enforce and add a few. For example, before we got to know exactly what she had, we were shooting in the dark for the longest time. So when Yara was born, we definitely knew there's something wrong. So the first thing we noticed fast, apart from the PID, she also has Down syndrome. So that's the first thing we noticed when she was born. But as time went by, we started noticing other things that she had. For example, she had this pneumonia that seemed not to be responding to any intervention that was being done to her. And as God would have it, Dr. Dan also had another patient who she was dealing with who had something close. So by the time she was called in to deal with Yara, she kind of had, can I say, a notion on what might be the problem. Though immediately we didn't go straight to think it's an immunodeficiency. So we did various tests. We did like Crohn's disease, for example, which came out negative. We also did one for DiGeorge and many other crazy big diseases out there. So the challenge I had first was when they would come as negative, you get mixed feelings. So in one side, I'm glad that she didn't have any of that, but in the other, we still didn't know what was wrong. So time was not on our side and she was getting worse. Apart from that, just as Dr. Baraza has mentioned, it's expensive. Doing this test is very expensive. And most of them are not done here. So there's also the issue about time. By the time you wait for the results to come, then you go to the next test. Everything was just crazy at that time. Not to mention she was born in 2020, and that was the period of COVID. So there's just so much that was happening. And yeah, these are some of the challenges that I faced during that time in the beginning before we were diagnosed.
Yeah. Maybe one more thing I could ask is, how has your experience been dealing with health professionals? Are there any specific areas where you feel more awareness is needed?
Yeah, definitely. So maybe I can just start from the history till now and say in the beginning it was very difficult for me because you find that when you go to hospital, I'd mentioned that my daughter has a PID and some of them would look at me like, what is that you're talking about? And when they're handling her, I had to be a little firm on the way to handle her because, apart from insisting on masking and, sanitizing and all that, there's still some things that we needed to do to keep her environment safe for her. So some healthcare professionals who I met and encountered at that time did not understand that. Another challenge is even the few who had heard about PID still did not know the severity of it. So you find, like when I go to hospital, before we get an admission, it will take long because I have to start explaining what has to be done, the conditions that Tiara needs. And you see that's time consuming because you find sometimes you're there and it's an emergency and she needs an intervention right away. Another challenge is because of this, I only have 2 healthcare providers that I can actually access, only 2 hospitals. And that's because she's been there since birth. So they kind of know how to deal with her, at least, though I still have challenges still. It's like if I meet a nurse who's never met Tiara, then I have to start again close to educating what PID is all about. So yeah, it's a continuous process.
Okay. Thank you very much, Helen, for sharing your experience with your daughter in this journey. We wish you all the best. And of course, we are grateful that you have had doctors who have been very helpful and supportive in this process. And like you said, there is definitely room for improvement and more awareness. Now, looking to the future, what improvements or changes would you like to see in the healthcare system or better support with to patients with primary immunodeficiencies or maybe rare diseases in general? What changes do you think would be helpful?
Just reiterating what Dr. Baraza said, I think it's important if you had newborn screening, because that would help in a lot. The interventions and treatments would start immediately. And we will not be caught in the funk of people losing their lives because of a delayed treatment or the wrong diagnosis. So newborn screening is important. Also affordable genetic testing, because you find that these tests tend to be very, very expensive. Even the ones that are within locally are quite expensive, without even mentioning the ones that you have to do out of the country, like India, South Africa, just to name a few. Not everybody can afford that. This is Kenya. Not everyone can afford the kind of testing that is required for this. Genetic counseling. I'm actually surprised Dr. Baraza said there's a genetic counselor in Kenya. I had no idea, because I think this is like super extremely important to have a genetic counselor to take you through what this condition entails, to make you understand and go with you through that journey. Because even till now, it's been close to 4 years, but some things are still foreign to me. So you find I still have to keep reading more, engaging with others out there and even locally who've gone through the same experience. But it would be the same, it would be different if a genetic counselor was part of the journey. Yeah, of course, affordable treatment, because, for example, my daughter every month goes for IVIG, which is quite expensive. So, and not every hospital has it. So even the few that I go to, which are the 2 hospitals that I mentioned earlier, I don't even know how to explain it. It's just too much. It's something that you can't do without, but by the time you're leaving that place, you've spent a lot of money. For someone who doesn't have insurance, for example, it's something that they will not be able to manage. So that means then, something happens on that part. Either the patient loses their life, or life just becomes crazy for the people, both caregivers and patients living with the PID condition. The biggest thing I'd ask for, and I think this would be the low-hanging fruit, is a multidisciplinary approach to treatment with the patient. So even as the doctors sit and deliberate on a way forward with regard to a patient's treatment, it would be good if they added the patient or caregiver in my case, because I feel there is something that we can bring in from the experience that we've had working in this journey that might not be medical, but it can also help with the process. So that for me is like one of my top 3 that we're part of the process, even as they're having the discussions, want to be part of the discussions. Yes.
Thank you very much, Helen. I think I would just like to echo your parting shot that our multidisciplinary approach is important, an approach that involves the medical experts as well as the patient or caregiver, as the case may be. I think now we can move on to the question session. We have some questions in the chat. Dr. Baraza, I don't know if you can see the chat, or should I read them out? Maybe I'll just read out one question, and maybe Dr. Baraza, you can maybe address this one. So there's an attendee asking where or who should we refer a patient with suspected PID?
Okay, you can refer to KNH, either to Dr. Anne-Marie, who is a pediatric infectious disease specialist. Dr. Dana Marangu is there as well, but she's not there right now. She's away. I'm there. You can refer to Gertrude's. I'll just mention the hospitals and I'll explain why. You can refer to Gertrude's, either attention to Dr. Mbozia, who's a pediatric ID, there's from the lab, Dr. Cabera and Dr. Maranga, we help evaluate these patients there. Or you can refer to Aga Khan, to Dr. Angela Migoa. She's a pediatric rheumatologist. So why I'm mentioning these 3 hospitals specifically is because, you know, we've had, you know, like the people I acknowledged, the different doctors from this hospital working in this area. And we've actually also worked with the International Patient Organization to have these 3 centers recognized as, you know, centers that take care of patients with PID. So any of those is fine.
Thank you very much. I think I would also add that if the patient is willing to also join a patient support group, you could refer the patient to either Primary Immunodeficiencies Association, which is myself, or Rare Disorders Kenya, which also provides like social support to patients and caregivers taking care of people with rare conditions, including primary immunodeficiencies. Now, there's another question here, and I think maybe Helen, you can answer this one. How much is the IVIG? I don't know if you're willing to answer that, but yeah, there's a question on the chat about that.
Yeah, so the drug itself costs 60, but it's very hard to isolate it because, for example, when we do go to hospital for her IVIG sessions, there's also the prophylactic medicine that she normally takes every day. So you find by the time, and we normally do it overnight because it takes 4 hours for the IV. So by the time we leave the next day, we are talking about minimum of 250,000 per session, per visit. And that is on the shy side. So on the 1st of this month, we were there and we did 2 nights. Of course, she left with her medication and she had to have another intervention done on top of the usual IVIG. So the bill was double that. And that's why I'm saying there's something that needs to be done because it's extremely expensive. It's a condition that if the government does not do anything about, then we're talking about, you know, the numbers of the mortality will just rise. Yeah.
Yeah, thank you for that. Very expensive. So you said the 250,000 is every month. How often does she get her IVIG?
She goes in every month. Yeah, so every
quite
end of
expensive.
the month, yeah, it is.
Okay. Maybe one more question for you, Dr. Baraza. There's a Nick Kamau who's asking, granulocyte transfusion therapy as a potential management strategy for PIDs. Is that a possibility?
Well, I would say no, because granulocytes and neutrophils, they don't live very long. They die after 6 hours. So it would just take we'd have to utilize too many resources to always have, this running bank of granulocytes. For cases where it's a neutrophil defect or a granulocyte defect, then if it's not functional, if it's a neutropenia, then there's a growth factor, Neupogen, which is administered maybe every 2 to 3 to 4 weeks, which drives the bone marrow to produce them. If it's a functional defect, then that will not work. But I think it would be impossible to transfuse granulocytes. They actually, even just like you collect whole blood, like the blood that's collected for transfusion, after a day, there's hardly any granulocytes still alive if you're going to transfuse that blood. So, no.
Okay, thank you for that. I'll ask two questions together, and these are both to you, Dr. Baraza. One is the doctors you mentioned who can be referred to for suspected PID were all pediatricians. So there's a question on who should they refer an adult with suspected PID? And second question is, should all children with cystic fibrosis be evaluated for PID? Dr. Baraza, are you there?
Okay,
You
I'll
may
start with
have
the
lost.
second one.
Sorry, go on.
So that mutation in cystic fibrosis, the CFTR, adult.
Are you there? I think you're breaking up. I didn't catch you. I don't know if it's just me. Do you mind taking that again, Dr. Baraza? Okay, it looks like we may have lost Dr. Baraza. Nelson, I think I'll hand back to you.
Yes, Cynthia. I can see Dr. Barasa is still with us. I think she's having some technical difficulties. I don't know whether you are able to complete the Q&A.
Yeah, it's probably technical issues. It looks like now she has dropped off. But I think we were at the tail end. We had addressed most of the questions. I would have liked to thank her for, taking her time to take us through the presentation, but she has dropped off. Helen, thank you very much for sharing your patient experience. I see Dr. Baraza joining again.
Sorry, I think, I had an internet problem. I've logged in through my phone. So for adults, I would actually, I think depending on the phenotype, if it's more of an infectious disease phenotype, I would send to an infectious disease specialist. If it's like an autoimmune manifestation, especially cytopenias, then that would be a hematologist. If it's other autoimmune manifestations, then I would send to a rheumatologist, an adult rheumatologist. If it's severe allergies, then to an allergist. So for the allergist is Dr. Priya. And I think the information on all these specialists is available. Dr. Ombajo, Dr. Mary Beth Maritim for infectious disease, and so forth. So it would depend on the phenotype. But I think as you're referring these patients, then you need to indicate if you suspect that it could be an underlying PID and why you suspect that it could be an underlying PID, just so that it's not forgotten. Thank you.
Thank you very much, Dr. Baraza. Maybe a final parting shot before we finalize from you and Helen.
So from me, I think I've said all I need to say. Maybe I would actually ask if we can get a parting shot from Dr. Walong, because I see he's on the panel, as well as Dr. Marangu. I think that would be, they can give my parting shot. Thank you.
Thank you, Dr. Baraza. Maybe Helen, you can go next. I think Dr. Walong and Dr. Marangu may have dropped off. I don't see them online. So maybe Helen, you can just give your parting shot.
Well, first I'd like to thank you, Dr. Anbaraza, Cynthia, for this opportunity to speak about PID. I'd say we've come a long way from 2020 till now. There's been a big improvement. When I go and see the participants here and I'm seeing all these doctors who've logged in, it gives me hope that the future is bright when it comes to treatment and maybe diagnosis of such patients. I know there's so many rare diseases and it's very hard to diagnose all, but at least starting this conversation now, and especially on PID, it's a good start. Maybe just to add one thing or two that I didn't talk about earlier, when I was talking about some of the future improvements, maybe I can just say such CMEs, like the one you're having right now, this is a good pointer towards what you can have in the future together, towards also the kind of the medical practitioners that we'll be having would give me more confidence knowing at least that there's someone who knows about this condition and there's an interest. And maybe also to invite more healthcare providers and medical practitioners to join patient-led groups to interact with us also. There's a lot of exchange and learning that we can do together, us as those living with and caregivers of the people living with such conditions, and also you from the scientific part of it. It would be good to work together in this, and I hope to see more of you even as we continue engaging in future. Thank you.
Thank you very much. Thank you very much, Helen. Definitely, there's learning on both sides from the patient and caregiver's perspective and also from the scientific side. So collaboration is key. I see Dr. Marangu is now online. Dr. Marangu, would you like to say something before we finalize?
Thank you very much for the opportunity. I'm just so proud that you had this talk with more than 1,000 participants on the call. And for the leadership from Dr. Baraza, Cynthia, Helen, the associations and the groups that you have, I'm just echoing the collaboration and the cooperation that is needed, multidisciplinary amongst health workers as well as patient and caregivers. So this is really, really great. Kudos, and to many more. Thank you.
Thank you very much. Nelson, I'll hand back to you.
All right, thank you so much for the session. It has been engaging and enlightening. Of course, it goes without saying that we do look forward for another session like this. So if you can organize, we'll be willing to host you again. And to the participants who are still with us, a few announcements. For the PPB, I know we have been following up, or rather you've been asking us about your CPD points. We are following up with the PPB and working on this so that we can upload all the sessions that we have conducted, so that you can be able to subscribe for them and then receive your CPD points. We are looking to make some progress. We have made some progress, and we are at least looking to complete the process by next week. So we will notify you through the normal channels that we have on the successful uploads that we have made. For KMPD, for KMPDB, you will the lists are uploaded to the ICPD portal, and the CPD awarded is automatic. So you should be checking on your account to see the status. If you are facing challenges or something hasn't reflected on your account, you can reach out to us through the normal channels that we do have, mainly knhcpd@gmail.com, and our team will be able to assist you and see why you are not receiving the points. For the COC, I can see questions have been raised as well. COC, we are working with the COC as well. We're just following up with them to see how far the progress is, and we will let you know once we have made a successful endeavor. And for the NCK, the points will be sent to your email addresses. As per the NCK rules or other regulations, the points are only valid for 48 hours from the moment that you will be receiving them. Thank you once again for being with us for this session. We will be back next week with more sessions, so be on the lookout on your emails and also for your WhatsApp and our social media pages for the next upcoming sessions. Thank you and have a good afternoon.
Thank you.